Uh, Welcome everybody. So this is it's my pleasure to meet you here in this discussion and to be with you together to discuss an important topic nowadays. All the people, they are looking for treatment for COVID-19. All the world, they are looking for the specific treatment, and still all the treatment are under investigation. All the scientific, they are working hard to have the treatment for COVID-19, as you know, and it's different from different trial, either from antiviral or plasma or anti-malaria, but still all under investigation. So it's our pleasure to have this discussion together. We'll have some discussion with the different doctors to know about their experience from different countries. So first, I will introduce Dr. Our speaker today, Professor Yassen Al-Arabi. He's a professor of respiratory from King College, King Abdulaziz, and Professor Muhamed Al-Maliky from cardiologist from Harvard, Boston. And our discussion panel is Dr. Professor Khoja and Professor Salman Rawaf. Welcome, everybody. Dr. Yassen, can we start?
Yes.
Yeah, we want to discuss about your experience in treating patients for COVID-19.
Very good. Thank you very much, Dr. Lulwa, Dr. Salman, for the kind invitation. It's my honor and pleasure to be with you today. So what I thought is to give an overview, brief overview of the current understanding of antiviral agents for COVID-19. And this is important to put it in the perspective of what type of study design. Sometimes we hear some of the studies on the news, on the media, without understanding the context of the trial and the design of the study. So I'm going to specifically talk about chloroquine and hydroxychloroquine, which, as you know, a lot of discussion has been around this topic. Then I'll talk about lopinavir, ritonavir, and then remdesivir, and the combination therapy of lopinavir, ribavirin, and interferon. So what do we know about chloroquine and hydroxychloroquine for COVID-19? Just a reminder, chloroquine is anti-malarial drug. It's also used in extra-intestinal amoebiasis. Hydroxychloroquine is commonly used for patients with lupus and rheumatoid arthritis. It is also anti-malarial drug, but has significant anti-inflammatory effects. But both drugs have been shown to have antiviral effects in vitro, and they do have immunomodulatory effects. So a study in vitro showed that chloroquine, as well as remdesivir, effectively inhibit the novel coronavirus, which now we call it SARS-CoV-2. And there's a lot of news came after a Chinese news release says that chloroquine shown to be effective in COVID pneumonia. It was an interesting press release that was not followed by publication, actually. But it created enough interest in this drug around the world. Then there was a small case series from France of 26 patients who were treated with hydroxychloroquine, and the azithromycin was added at the discretion of the treating teams. This was not a randomized control trial, it was just an observational study. And these patients were compared with untreated patients from another hospital or patients who refused the protocol. Now, many of us who are familiar with study designs will tell you that this comparison is problematic. So comparing patients from another hospital by itself leads to differences related to different setting. Comparing with patients with refused protocol, these are different population actually. Nevertheless, the 26, there were also 6 patients lost follow-up, so another big problem. So the authors reported significant reduction of viral carriage compared to the control. So the main outcome was reduction in virus in the nasopharyngeal swabs and lower duration of carrying the virus. So the primary outcome was mainly viral outcome. But out of desperation with the cases of COVID going up dramatically, this was on the news everywhere and was adopted by many guidelines as a treatment for COVID-19. Then the same group did another case, a cohort study, small one, 80 patients now, and again hydroxychloroquine for 10 days with azithromycin. And then these patients were treated within 5 days of onset of symptoms. And they reported that all patients survived except one. There were 3 patients required ICU and 12 patients required oxygen, and few patients remained hospitalization. The main result that this treatment was associated with clearing the virus from nasopharyngeal swabs by day 7 in 83%. The problem with this study, there is no control group. So you don't know, this may be the natural course of the disease that people clear their virus. And clearly these were a group of mild cases. Also, there was a lack of complete follow-up. Many patients did not have a follow-up. So 17% were in the hospital at the time when the study was published. But again, this type of studies where a lot of major decisions in many national guidelines to incorporate hydroxychloroquine were made. Then people start to ring the red flags. This is a study. This is a study looked at the cardiotoxic effect of hydroxychloroquine. This is a cohort study of 90 patients and showed that hydroxychloroquine was associated with the QT prolongation, and this was greater if it was combined with azithromycin. Then a Brazilian clinical trial, randomized control trial now, was conducted. This was the first randomized control trial of chloroquine. Took patients who were hospitalized with severe COVID and randomized to chloroquine 600 milligram for 10 days and 450 for twice daily for 1 day. The study was stopped by the Data Safety Monitoring Board after reaching 81 patients. They found actually that chloroquine was associated with increased risk of death, 39% versus 15%. And QT prolongation happened more often with the high dose. This is a trial of high dose versus low dose of chloroquine. 2 patients had VTAC before death. The study has some limitation. It's a randomized controlled trial, which is great, but there were some imbalances in the trial. More patients who have cardiac disease were randomized to the high dose arm. It is a small study, and very often they use azithromycin and oseltamivir. Both are known to prolong QT. So when combined with chloroquine, the effect could be more prominent. A large cohort study from New York of almost 1,400 patients compared patients who received hydroxychloroquine to those who didn't. As you would expect, patients who received the treatment were older, so more older patients who have chronic problems, more likely to be treated, So the two groups are not the same. So what the authors done, they did multivariate analysis and they did propensity score adjustment. And by doing this, there was no difference in the primary outcome of death, did not make a difference based on the propensity score adjustment. Limitation of the study is being observational. And of course, you cannot exclude residual confounding. Then there was a study from China, 150 patients, where they compared standard of care versus hydroxychloroquine. The primary outcome was negative PCR within 28 days. And you could see from the Kaplan-Meier curve, these were identical. The study patients were enrolled after 16 days of symptoms onset. So that's very, very late, actually. So you could argue that there was no difference because it was late. And the treatment was given for 2 weeks, which is longer than most protocols would do. The study did not reach the target sample size. Another large, cohort study from France of 181 patients showed no difference again in survival without ICU admission, as shown here. And then the study that has provided us the strongest evidence is the results of the recovery trial. And what we know about this so far is from press release. The study is not published yet. So hydroxychloroquine, this is a randomized controlled trial of multiple agents. In the hydroxychloroquine arm, there were 1,500 patients compared to 3,100 patients. The primary outcome of 28-day mortality was actually slightly higher with hydroxychloroquine, with adjusted ratio of, with a hazard ratio of 1.11, with a confidence interval that is crossing 1, but barely. So it's actually a little higher than 1 generally, suggesting harm, p-value 0.1. Technically, no difference, but suggesting possible harm. No beneficial effect on hospital stay. We're going to hear a lot of this debate about hydroxychloroquine from the recovery trial, because the counter-argument that the study used a very high dose of hydroxychloroquine. 800 milligram loading dose, 6 hours later, 800 milligram, then 400 milligram, 12 hours, and 400 milligram. So it reached almost above 2,000 milligram in 24 hours. So people argue that this might have been very high dose. But the consequences of this large trial were huge. The UK government suspended recruitment to all hydroxychloroquine trials. The WHO stopped recruitment into the Solidarity clinical trial, the hydroxychloroquine. The NIH stopped hydroxychloroquine clinical trial. So we will know more about this as more studies get published in peer-reviewed journals. Next agent is the lopinavir-ritonavir, or in general, the HIV protease inhibitors. These have been used, of course, these are standard therapies for HIV, but they have been used in SARS and MERS. There are no data in vitro against SARS-CoV, but it is possibly effective by affecting the protease, affecting its protease inhibitor. So lopinavir-ritonavir, to make long story short, there are 2 trials that we are aware of. This is a Chinese trial of around 200 patients who were randomized to receive lopinavir versus standard of care. Patients were enrolled on average on a median of 13 days. So imagine somebody has symptoms, after 13 days get treated. This is really late. Mortality was not different, although in the lopinavir it is 6% less, 19% versus 25%, but it was not significant because of the sample size. Length of stay was shorter with the lopinavir, 6 days versus 11 days. Hospital length of stay and time to clearance was negative. This was not a blinded clinical trial and was underpowered. So the interpretation was that this is negative, but I would say it's not entirely negative because patients were treated very late, and it is possibly antiviral therapy are effective early on. I mean, you'd expect with a viral infection, the virus will be effective in the first few days, maybe first few weeks, and maybe the immunomodulation and steroids, as we've seen from the recovery trial, may be effective after the first week. Again, the recovery trial in press release, this is recent, about 1,600 patients were randomized to lopinavir-ritonavir versus more than 3,000 patients usual care. These were patients not very critical, only 4% were mechanically ventilated, 70% were on oxygen, and 26% were not on any respiratory intervention. So they're not even requiring oxygen. So these 26% you could consider them mild. There was no difference in the primary outcome of 28-day mortality. Remdesivir is an agent that is known to be effective in vitro against SARS-CoV. Remdesivir, if you remember, it is also effective against Ebola. It has been tested in one of the large Ebola trials. In an animal model, it has shown to reduce the viral load of SARS-CoV and reduce lung damage. So it has been used in a compassionate use around the world, and the experience with the compassionate use was published of 61 patients receiving, many of them, around 57, were receiving mechanical ventilation, and this compassionate use reported clinical improvement. But this can't tell much about this. This is no control group, can't tell much. Then there was published the clinical trial from USA, the NIH trial of remdesivir of hospitalized patients with laboratory confirmed SARS-CoV. This is, in this trial, patients were randomized to remdesivir for 10 days versus placebo, and the primary outcome was time to recovery. The median time from symptom onset to randomization was 9 days. Now, this trial is a well-done trial. It's a large trial, 1,063 patients underwent randomization. But because of the outbreak, things were reported even without completing outcomes. And I think what people need to keep in mind that put this in the context. So out of 541 who received remdesivir, 132 were continuing the trial, and you don't have outcome data for them. Out of 522, you have 169 were on the trial when the study was reported. So we're not certain completely, really, if these results would be the same if all these patients finish their outcomes. So the primary outcome was time to recovery, and that was shorter in remdesivir, 11 to 15 days. But mortality was not different. Mortality was not different between the two groups. It was secondary outcome, the 7% versus 11%. And these are the Kaplan-Meier curves. The other thing interesting to me, here you could see this is the overall time to clearance, time to recovery. And you could see separation with the remdesivir being higher. if you take the patients who were not receiving oxygen, very mild, no difference. And the patients who were very severe, no difference. It's a group that in the middle, the one only receiving oxygen. And I don't have very good explanation for this. Usually, you would see dose-effect relationship. So you would, if mild cases, no effect, more severe, you'll see some effect. The very severe, you'd expect bigger effect. But here, it didn't happen this way. So, so like here, patient with ECMO, essentially no difference, or mechanical ventilator or ECMO, no difference whatsoever. So just this group receiving oxygen alone, kind of unique. Then another trial where compared Remdesivir for 5 days versus 10 days and showed it did not make a difference. 5 days versus 10 days did not affect the clinical status on 7-point ordinal scale, which is this one, death or hospitalized with different severities. A Chinese trial for Remdesivir of this double-blind randomized control trial was planned for a larger sample size, but was stopped because cases were declining in China, showed no difference in outcome. So the question for Remdesivir, I think people like to say that it is effective and highly recommended, but there are still a lot of questions about its use. Of course, you add to this that it's very expensive and not available, not widely available. Triple therapy, this is a clinical trial of combination of interferon beta with lopinavir and ribavirin in cases of with mild SARS-CoV. And this study showed significant improvement in clinical symptoms and also even also in viral load. So treatment with interferon beta, with lopinavir and ribavirin was effective in these mild cases. There are emerging studies, more emerging studies about interferon beta being effective. There are other agents which I'll pass by quickly. Arbidol, small clinical trial.
You have 2 minutes to finish. You have 2 minutes to finish.
Yeah, I'm almost finished. This is a trial of Arbidol with lopinavir, no difference. Favipiravir, another clinical trial in China, suggested it might be beneficial, but more studies are needed. I think the issue is we have bad disease that is very common, and there are a lot of agents to test, which is hard to do in a standard randomized control trial, where you do one trial and then another trial and a third trial. And now we are participating in a large clinical trial called REMAP, Randomized Embedded Multifactorial Adaptive Platform, where multiple agents can be tested at the same time with adaptive randomization, where the number of patients in each arm is affected or influenced by outcomes. So at the same time, we're testing antiviral, macrolides, steroids, immunomodulation. Otherwise, it will take ages to be able to answer. So much more efficient. I'll conclude with these 2 slides. This is the NIH guidelines for COVID treatment. What's recommended for patients with severe, hospitalized patients with severe COVID? Recommend the investigational Remdesivir in patients who have saturation of less than 94% or requiring oxygen. Also, they recommend Remdesivir for patients with mechanical ventilation or ECMO. But actually, I showed you the data that is really doesn't show a difference. So I don't know. I question this recommendation. Patients with mild COVID, there are insufficient data to recommend Remdesivir for or against Remdesivir. Chloroquine and hydroxychloroquine, the panel NIH recommend against using this unless in a clinical trial. and recommend completely against the use of high-dose hydroxychloroquine. For other agents, they are recommended only within clinical trials. Thank you very much.
Thank you, Dr. Yassen, for the interesting presentation and your slide. We will move now to Dr. Muhamed. Dr. Muhamed.
Yes, I'm trying to, here we go. Okay. Is this clear? You can see it? Okay. Trying to, okay, so I will provide an overall management approach to COVID as per severity and the protocol that we use in our center at the University of Pennsylvania, which is probably generalizable to most, at least university hospitals around the US. We interact quite a bit, and this gets updated all the time. So the COVID patient are generally divided into 5 categories: the asymptomatic, mild, the moderate, the severe, and the critical. Luckily for us, that the asymptomatic and the mild constitute about 80% of the cases, with a very high chance for recovery. What Dr. Yassen has beautifully elaborated on are the cases that are from moderate to severe that receive more advanced therapy that mostly are under investigational trial, and there is no specific therapy that currently is directed at the virus that has shown superiority over the other. As we know that when the pandemic started, there was a big wave about the chloroquine and hydroxychloroquine that has at this point ebbed. In fact, the evidence shows that that is more toxic than useful, especially if it's combined with azithromycin due to the QTc prolongation. So now we go category by category. What do we do for the asymptomatic patient? So those people tend to have the cardinal symptoms or no symptoms. So fever, cough, dry cough, some myalgia, loss of smell, loss of taste, and the severity of these symptoms vary from one patient to another. And those people tend to do well with only symptomatic treatment. There's no any specific treatment that needed to be directed at those patients, and they can be treated at home safely with monitoring and the usual supportive treatment. So that is a very clear category. The second one is the mild hospitalized with a mild form of the disease, and mild is defined as pulse oxygenation more than 94%, and no oxygen needed. They can be admitted for monitoring and be provided symptomatic and supportive treatment with no specific therapeutic. Of note, corticosteroids can be applied to this category, not for COVID per se, but if it's indicated for other clinical presentations such as COPD or something not related to COVID, it can be applied. Otherwise, is not indicated. The moderate version, defined as hypoxia, but rectified by low flow oxygen provided through nasal cannula. 2 liter, 4 liter, more or less. Those people can be, or perhaps in most settings, should be admitted and provided the usual symptomatic and supportive treatment. And the specific therapeutics can be applied in this category, even though there is no overall agreement among scientists and people of concern that this makes a tremendous difference in the outcome. With the exception of Remdesivir, perhaps, as we have seen with Dr. Yassen presentation, and he justifiably said that he does not have an explanation. However, I sort of was going through the literature, and there was a beautiful diagram that divides the COVID into 3 phases. The phase number 1 is the viral. So there is viremia, and the virus can be retrieved from mucous membrane without pneumonia or mild pneumonia. And then the second phase that is mostly pneumonic, that affects the lung with various degree of pneumonia, without florid respiratory failure. And this category tend to perhaps, the relative response to antiviral in this category may be theoretically attributed to the fact that the virus is limited in its damage to the lung tissue and has not gone into causing sepsis or systemic response, i.e. septic shock and organ failure, where the disease takes another life of its own, that other therapeutic modalities need to be directed, such as anti-inflammatory or immunomodulators and so on. So it has gone from sort of the direct viral effect into something more severe, triggered by the virus, but has something to do with the inflammatory response. The role of a steroid in the moderate version and the moderate degree has been seen in the recovery trial. However, it should be directed. I mean, this group of patients can be further risk stratified to predict the trajectory of the disease. If they have comorbidities, if they have a tendency to go down south and clinically, then dexamethasone can be of benefit. Definitely now the recommendation, anyone who needs oxygen could benefit from dexamethasone. And the dose is a standard 6 milligrams PO or IV from anywhere between 5 and 10 days, depending on the setting. This group also is appropriate for the expanded access convalescent plasma in a clinical setting, or the, I cannot see this one, but let me see here. Or the other 2 trials that are being conducted, and also besides the other trials that have been described by Dr. Yassen. Let me see, here's my, the Remdesivir plus baricitinib, which is immunomodulator, or Remdesivir plus placebo trial. So the moderate version also, the patients are appropriate to enroll in this trial. Again, this is in a clinical trial setting. Again, I forgot to mention that Remdesivir is not, I mean, only indicated, only being used as a compassionate use approved by the FDA or in a clinical trial setting, but is not routinely indicated, clinically indicated for every case. And in our hospital has to be approved by the infectious disease team. Now, the severe form of the disease here, those defined as people who requires high flow oxygen through nasal cannula or non-invasive positive pressure ventilation in the floor, on the floor, or in the intensive care unit, they can benefit from the antiviral agent, the only one that we use now in the US, Remdesivir. Dr. Yassen mentioned that it's not widely available around the world, tends to be very expensive. They benefit also from steroid, dexamethasone, the usual protocol, which is 10 with 6 milligrams IV or PO for 10 days. The duration of dexamethasone tend to be more beneficial with the severity of the disease. So we tend to use it as 5 days for milder cases, moderate cases, and up to 10 days for severe cases, but no more than 10 days, and the patient should not go home if they get discharged on it. 10 days, stop it, and that's it. The same thing applies here as far as the plasma and the trial medications. And then the critical version, the critical group are those people who are on mechanical ventilation. So they have ventilator-dependent respiratory failure and or septic shock and organ dysfunction and or organ failure. Actually, this is meant to be an E or a multi-organ dysfunction, multi-organ failure. We use in our hospital now. The trial shows that probably the antiviral is not very useful in this category. However, the recovery trial has demonstrated the highest value in severe and critical patient with a significant p-value. And those people, you can also apply, you can also try them on a plasma. And perhaps the combination trial in the critical patients is not as indicated as it is for the moderate and severe. And in addition to these standard therapies now we use for a critical patient, then we treat all other secondary effects. If they have a superimposed pneumonia, we apply the agent that is appropriate, plus treating them for circulatory failure with all the appropriate agent that we have. So the chloroquine and hydroxychloroquine has gone out of favor. We don't use it. We don't use azithromycin as routinely as we did before. We use it only for critical patient with secondary pneumonia superimposed on the viral pneumonia as it clinically shown. All other agents that have been talked about in the media, zinc, vitamins, has not shown a clear benefit. We don't advise neither for it or against it if there's no demonstrated harm. And this is actually a promising outcome that came out of the recovery trial. And this slide only concerns the steroid use. As you see that the 28 mortality in patient on invasive mechanical ventilation, they benefit the most. You see if they are treated with the usual care, their mortality is 40.7% and 29% if they receive the usual care plus steroid therapy. And the p-value is quite significant. Then the benefit decreases a little bit for those people who require oxygen, but not on mechanical ventilation, but is still significant with a p-value of 0.0002. However, if patients are not hypoxic and do not need oxygen, you see there's a possible harm, and they could die more if you put them on dexamethasone versus standard of care alone, with the p-value suggesting harm more than benefit. And I will perhaps stop here. That's we're happy to receive any question. So I think we both of us somehow appreciate the presentation by Dr. Yassen, who went into depth to demonstrate the possible benefit versus harm for all the agents and where we are with the science of it. And this is an example of a protocol that we apply in our hospital, University of Pennsylvania. I think Harvard uses the same protocol, and this is where we are. Thank you very much.
Thank you, Dr. Muhammad. Thank you for your interesting and informative presentation. And we will move now to Dr. David. Dr. David is with us on call.
Hello.
Hi,
yes. My name is Dr. David Rawaf. I'm currently working in Epsom St. Helier Hospital. My usual job is in trauma and orthopedics. However, as part of my training, I was in intensive care medicine late last year, and just before the coronavirus outbreak, I was redeployed from the ITU intensive care unit at St. Helier to Epsom. So all in based in South London, and I've just been asked to join today to share my experience. It's more of a, you guys can lead the questioning by all means, but to also share my experience of what it was like in the initial stages of the outbreak in South London, and what it was like in from a junior doctor's perspective. So I don't have any presentation, unfortunately. I'm on call, so I don't have the computer with me. However, I mean, by all means, please ask me any questions about the experience. But I can, if you want me to, I can tell you a little bit more about what it was like.
Yes, if you can tell us about your experience in ICU.
Okay, sure. So when we first started in the redeployment, we essentially had converted an elective orthopedic center into an intensive care unit. So our first issue was obviously oxygen. A lot of the ventilators that we had, and I'm sure many other countries and many other hospitals around the world have the same issue with ventilator numbers, is that we were using anesthetic machines that were simply recycling the oxygen and also absorbing the CO2 with soda lime. So we were running out of soda lime quite fairly quickly. We were also having issues with those particular ventilators accumulating quite a lot of fluid in the lines and in the machines themselves. So furthermore, the hospitals do have, from what I understand, a maximum supply or pressure of oxygen, or the rate at which the liquid oxygen is converted to gas is only a certain speed. And as a result, we were limited in how many ventilators we were able to run at the time. I'm sure the issue is the same across the world. Moving on from that, once we'd set up our essentially temporary unit, we started getting a lot of referrals and admissions into the unit. A lot of these patients were particularly unwell. They were all, you know, most of them were quite far on. So, you know, in terms of that slide that that we were just looking at now, these were the patients at the bottom of the slide. You know, the most severe type 2 respiratory failure, severely acidotic, you know, already had achieved, you know, maximum pressures on CPAP, and essentially we were starting to ventilate these patients for them. Some of them were with no medical comorbidities at all, very young patients, generally quite fit and well when you look at their clinical documents. So these weren't just old and frail. These weren't people that were particularly comorbidity you know, laden. And that was the first issue, was trying to find out, you know, how can we optimize these patients in this temporary setting. So we, you know, obviously our initial investigations involved bringing, you know, the lab and the radiographers into the intensive care unit. We had the barrier issue with regards to isolating that whole building away from the rest of the hospital. So we had the whole team within the unit. With regards to remdesivir and dexamethasone, I think these have been spoken a lot about today, and I think it'd be good to mention that now. At that time, so you know, obviously I've been redeployed back to my usual job in orthopedics as of last month. However, during that time, when I was when the outbreak essentially first started, we did not have any evidence to suggest that remdesivir would work. We also didn't have remdesivir in the hospital. Furthermore, dexamethasone was pretty much a standard, you know, mid to late stage addition to our treatment for patients. by the time we started proning these patients, we would consider steroids, but obviously we were worried about the long-term effects, and a lot of patients, bearing in mind the mortality was roughly 70% across those hospitals. If you were in ITU, the results unfortunately don't suggest that those patients did that well. We don't have that data, unfortunately. And obviously NICE guidelines, so that's the National Institute of Clinical Excellence, which provides the guidelines for the UK. They have replied to the use of remdesivir and steroids, and whilst dexamethasone has been acknowledged as something that will be beneficial for these patients, the questions are there to be asked about remdesivir still. Their official word is that when compared to placebo, remdesivir was associated with clinical improvements in some of the outcomes with fewer serious adverse effects. It's still not fully proven. It's still quite a gray area. And I do acknowledge and appreciate the work that our colleagues have done in the field to make sure that we can prove that it works. I have spoken to my intensive care colleagues recently, and they are still not using remdesivir in this particular hospital, just purely based on the fact there isn't enough evidence for us to continue using it. And also the problem is that the same with hydroxychloroquine, the same with remdesivir. There are already a cohort of patients using these drugs, HIV patients. There are patients with rheumatoid conditions that need the hydroxychloroquine for anti-inflammatory use. So the demand for the drugs are already quite high, and the manufacturing of the drugs is not high enough to meet the new demand that all these countries, and especially the UK, requires. So NICE guidelines don't just have a responsibility in protecting and ensuring that the latest and highest level of evidence is there, but also have a responsibility in protecting the supply of these medications and the cost of these medications to the public. Obviously, that would be different in countries where the medications are at a cost to the patient as opposed to the taxpayer. Furthermore, if you'd like me to continue, I can talk a little bit more about what it was like on a day-to-day basis in the intensive care unit from a junior doctor's perspective. It was very tough at the beginning. We did not have all the PPE that we needed. We were given 2 masks per shift, and so we would have to wear those 2 masks across 13 hours. That would give you 1 chance to go for your meal or for your toilet break. Furthermore, that was already tough as it was, and we were all just getting used to the PPE, the personal protective equipment. Things like nose ulcers and injuries to the face just from the mask rubbing. And furthermore, a lot of the masks were leaking. They started to introduce fitment tests, but a little bit too little and too late. And we found that actually most people were failing fit tests around the nasal area, just underneath the eye. That angle between the nose and the maxilla is quite sharp, and I'm sure you'd appreciate. People have different nose shapes. Some people, these masks are fitted for particularly just your standard nose. If you had a slightly larger nose, or if you had a slightly more prominent maxilla, these masks would leak, and as a result, we weren't considered safe in that working environment. But that was an issue in itself. Moving on to more about equipment, moving on to the patients, we were also struggling across the UK, not just in our hospital, with basic medications. We were running out of propofol. We were having to use paralytic agents rather than propofol in order to achieve compliance of the patient with the ventilator. We had a lot of patients fighting the ventilator during that time when we were running out of propofol. So that is something for all hospitals and all hospital managers across the world to make sure that the supply of these basic drugs are there. We were also running out of equipment like art lines and central lines. And like I was saying earlier, because we were changing soda lime in the recycling ventilators, in anesthetic ventilators. We were running out of soda lime. We were running out of filters that connect the tubes from the ventilator to the patient. It's the treatment of the patient obviously, revolves around medical management, but it also revolves around mechanical management. We have focused quite a lot on medication, but we do need to also focus on the actual logistics of mechanically ventilating these patients correctly. There was a lot of new doctors being deployed into an intensive care unit that have never seen an intensive care unit setting. I was lucky that I had a bit of experience, but I say a bit, it was only about 4 months. But in the grand scheme of things, we had 80 or 90% of all these doctors that suddenly turned up on the door, wearing all the PPE and everything, all very eager to help out, just didn't simply have an idea of how a ventilator worked. We managed to get around that by running essentially on the spot teaching. We were constantly teaching. Those in the know or had any ITU experience literally wore a different color hat, so that the doctors that didn't know what to do could come and find us very easily. Because the thing is, you can't really tell who is who once you've got all that equipment on. So we were doing teaching on the spot. We were training doctors how to do art lines on live patients. We were training doctors how to read and interpret arterial blood gases, and also adjust ventilator settings to match. It wasn't just the doctors that was, that were undertrained. It was also the rest of the multidisciplinary team. We had, classically in an intensive care setting, and prior to COVID, all our hospitals would have one-to-one intensive care nursing. Each nurse would be an intensive care trained nurse, what they call it, band 6 or band 7 here in the UK, but around the world, there's quite a higher level of training to get to that level, to be one-to-one with the patient. We were suddenly whittled down to, due to a mixture of lack of staff, sudden increase in number of beds, and also a lot of intensive care nurses getting ill. A lot of intensive care nurses were at home isolating at the beginning of the outbreak. We were down to essentially one intensive care nurse per roughly 6 or 7 patients. And those that were doing one-to-one nursing were either physiotherapists or physician associates or healthcare assistants. These are all medical practitioners that don't have that experience of tallying up every single aspect. Every single organ system needs to be tracked and registered and written down on our sheet in front of each patient. So we were getting transcribing errors. We were also getting issues with tallying up, for example, the amount of fluid balance that the patient had. It made things a little bit harder, made things a little bit trickier, and and again, we were teaching as we were going. It was not easy to do. However, we pulled through, and now as of today, actually as of last week, I spoke to my intensive care colleagues. We've actually come down from a total of about 70 patients across the 2 hospitals on a ventilator to 0. We have no coronavirus cases on a ventilator at the moment in our hospitals. We've opened up all the wards and the intensive care units so that they're not red zones anymore where you have to take your PPE on before you go inside. It's just standard precautions, just a mask and gloves. And thankfully the situation has improved. But looking back, the mortality rates were in the 70s if you were admitted to intensive care, and that was as of roughly May to June. So I think we dealt with the situation as best as we can, but I think as the coronavirus spreads across the world, we need to make sure that we're preparing, or hospitals around the world that are getting these sudden spike in numbers or admissions need to be preparing for such an eventuality. There needs to be a method for the hospital to be able to bring doctors and staff, other medical personnel from other teams They need to be ready to go to the intensive care unit. And we should be starting that from now. Not only that, we should be training medical students in intensive care, ideally in the penultimate or the final years, so that they are ready if they need to be redeployed. We've had quite a few medical students come across. Obviously, their electives, their foreign travel or their abroad travel period between medical school and working as a doctor was cancelled because no one could travel. But so we had a lot of those medical students come to us, and sadly, they just didn't have the expertise that we can provide medical students in the future. So, we need to make changes at a hospital management level. We need to make changes in the hospital, in the contracts for the medical staff, to say that we need to, you guys can be redeployed if necessary. We need to be changing medical school curricula so that intensive care is a focus towards the end of medical school. Furthermore, we also need to be making sure that the supply chain, the logistics are ready for such an eventuality, as we see the coronavirus spread and get worse across, especially America, especially the South and the West of America. For example, the hospitals need to be prepared for that eventuality, that their hospital may be over capacity. And that includes technical aspects such as I mentioned at the beginning, having enough oxygen and enough oxygen flow rate, and having the correct kind of ventilators. We did have a temporary Nightingale, they called it. It was a hospital over near the city in London that was ready for over 1,000 patients. But we were lucky we didn't need to use that. The hospitals across the country were able to manage the situation. However, I say manage, it was still not a favorable outcome. It's very tragic with mortality rates being so high. So we do need to learn. My worry is that looking ahead, we have a vaccine. Moderna, I think yesterday, released some news about their phase 3 trial of the current mRNA vaccine. However, just looking into the science of that, we do have an issue with the protein on the viral envelope. I think it's a protein S in particular, is very prone to mutation. And the issue is that, yes, we could have a vaccine in the next few months to a year. And yes, we could try and get all our treatments and prove that our treatments, medical management actually works. However, my worry is that as soon as that virus mutates, if we look at other coronaviruses, such as the common cold, we see that mutate almost every year, and yet we catch it every year, even though we probably hold some T cells that can create the antibodies for it, or encourage the B cells to create the antibodies for it. We need to be ready for a potential second or third or fourth wave, or even for this to be a yearly occurrence, but hopefully nowhere near as bad.
Thank you.
Thank you, Dr. David.
Thank you, no problem. Thank you for having me.
Thank you to discuss your experience. I think you have part-time in ICU.
It's been interesting, yes, absolutely.
Thank you, Dr. Lulwa. Thank you very much indeed, my good friend, Dr. Yassen and Dr. Muhamed. And thank you, David, for this vivid experience. I mean, we allowed you to go on and on because we were touched by it. And it tells a story. And really, I need to thank on behalf of everyone listening, the fantastic summary of what's available in terms of treatment, and there are a lot of confusion. Before I go to Professor Khoja in a minute, we have a question from Professor Faris Al-Lami from Iraq. And Professor Al-Lami asking practical question, when we should and should not use plasma, because apparently in Iraq now, everyone is talking about the plasma. They are feverish, so to speak. Everyone should have a plasma, even those with mild cases. And unfortunately, some doctors in the private sector we heard today from a meeting on COVID that giving a patient at home plasma.
So I want to hear from our two experts, Dr. Yassen and Dr. Muhamed, a few words about plasma, and then we move to Professor Khoja with his question. Dr. Yassen?
Thank you very much. Excellent question. It has been a theme from the beginning of COVID-19 is that under the public pressure, we rush to use medications or treatments that has not been shown to be efficacious or not been tested in proper clinical trials. Starting from hydroxychloroquine to just name it, so many medications, including convalescent plasma, where 20,000 subjects in the United States were treated outside clinical trial. There are concerns about this. I think we understand the pressure to use treatments and that we have to do something for patients. But if the treatment has no proven efficacy, this could be problematic. For the convalescent plasma at present, there are no data from clinical trials showing efficacy or otherwise. So using this for mild cases or even more severe cases should be done mainly in clinical trials. Perhaps, as Dr. Muhamed mentioned, in the more severe cases, when you're running out of options, might be reasonable if you don't have a clinical trial ongoing. But for mild cases or home treatment, I think this will be not justified, and you maybe get only side effects or maybe risk. The example of hydroxychloroquine is an example. In fact, as we are talking, the preprint of the hydroxychloroquine trial came out and showed actually hydroxychloroquine indeed increased mortality. So using these treatments without evidence could be not only not beneficial, but could be risky and could increase the risk of put people at risk. So that my answer is for mild cases, no convalescent plasma, maybe severe cases, maybe, but this should be done within clinical trials.
Yeah.
Over.
I mean, this is a very good point. Thank you very much indeed, because at least we can have a clear cut point like the hydroxychloroquine, which you described. Professor Muhamed?
No. I don't have much to add to Dr. Yassen's point. I will just reiterate, especially to the Iraqis, it seems that this is has become a sticky issue. In another presentation, the same question came. For the asymptomatic, definitely no plasma. For the mild cases, definitely no plasma. Then you have the moderate, severe, and critical. All of them are admitted. They are hospitalized patients being treated in the hospital. Whether to use a plasma for those or not is still, again, is still within the clinical trial setting. There is something to anticipate out of Mayo Clinic. There is a trial being conducted. I think for moderate, severe, and critical, and there is also another trial that we are conducting at the University of Pennsylvania for comparing convalescent plasma versus not for the three categories. There, I mean, its effectiveness at this point is only anecdotal. There is absolutely no proof for its effectiveness. In the hospital, clinical setting or healthcare setting, such as Iraq, where things are not standardized, I tend to advise against it.
That's a good question. I just received actually a very tears in my eyes reading this. I mean, can you notice maybe my face bit changed from a father who is in the health profession. Actually, he works in genetics. He's saying my son, who is 35 years old, was admitted to the hospital with a chest problem, then recovered. And one of the doctors asked him for a treatment which is cost 5 million dinar. I don't know how many dollars. I don't know. Don't ask me. You may know better than me.
5,000.
Must be something like what, $500, something like
no,
that.
$5,000 actually.
$5,000.
5 million is 5,000.
Oh my God! And it is actually the IL-6 inhibitor.
Okay. Yeah.
You know, and he said immediately after receiving this injection, my son, 35 years old, passed away. So none of you mentioned the ICL6 inhibitor, which apparently used in some of our Arab countries, you know, within the protocols, which we don't know what is the source of it. So I love to hear from you about this, because this is really just came to me in a message.
The use of immunomodulator, there are also multiple clinical trials on using immunomodulators, IL-6 antagonist and IL-1 antagonist. But I think the story that you gave is really an excellent example of we should be using this within clinical trials only. Yeah. Because the problem when people do treatments outside the clinical trial, you will gain no knowledge. We'll gain no knowledge whatsoever to help the future patients. This immunomodulator may have effectiveness in selected patients, maybe with the patients who have cytokine storm, but not in all patients. And in this patient who is recovering already, looks like, what's the point? I mean, I wonder.
It's called Actemera, but they are giving it almost, they recommend it for everyone now.
Yeah.
The relatives, they have to go because it's not supplied by the government. They have to go and buy it. And I started to feel there's some fishy things here even. You know.
The worry with these immunomodulatory drugs, sorry to butt in, is that they're going to be associated with an increased risk of secondary infections. If you're taking these drugs at home, you're going to be suppressing your immune system, especially IL-6 pathway inhibitors.
That's a good point.
And you'll be prone to something basic at home that can kill you.
Yeah. Dr. Muhamed?
I want to add, I mean, our understanding of the virus has evolved over time. And now we know that the systemic inflammatory response constitute a very significant portion of the disease. But the systemic inflammatory response tend to be the phase where patients are already in the ICU, either receiving mechanical ventilation, ECMO, or positive pressure ventilation. We assume once the patient reaches that stage that he's no longer in the viral phase of it, nor in the pneumonic phase of it. He's in the shock phase of it. And a few factors come to play where then at that point, sort of theoretically, at least theoretically speaking, that we can target the systemic response with either anti-inflammatory or immunomodulation. But even without even talking about the trial, just sort of common sense, I don't see any role of them in the mild, in the asymptomatic mild or moderate. So maybe there is for the severe end, but we have to wait. As we see, we can medicine, we cannot depend on anecdotes. The problem with anecdotes in a culture like ours is that stories propagate. And some, the son of so-and-so has taken this medication and has improved. And so on, then somebody puts on something on Facebook and people go on to try it. And it leaks sometimes to the clinicians themselves. It's like, well, since we have an anecdote, maybe 2, maybe 3, maybe 4, maybe in this case it worked. But, as scientists and physicians, we just don't operate this way. And even with the anecdotes, we should not really rely on that.
Yeah. Thank you. This is great. Professor Khoja?
Thank you so much, Professor Salman. This is great. You are continuously producing a very effective and welcome webinar for different subjects. And also I am pleased to hear from Professor Al-Arabi and Professor Al-Maliky, Dr. Lulwa, and our son, Dr. David. This is great. Really, I have been taken by the stories of Dr. David and how junior doctors, they are really great doctors. They are not only junior, they are not anymore junior. You are a great person, Dr. David. So what is great, and you should be proud about it. Actually, I have one question for you, Professor Salman, and the rest of our excellent, eminent speaker, and the other two is for each one of them. So let me ask the common question. Why even we have a strong public health publication based on evidence, still there was unclear guidelines of therapeutic management of COVID-19? I mean, if I am a family practice doctor, and this is through the groups of family practice, we hear so many things. Then after 1 week to 10 days, 2 weeks, there is another revisiting the whole guidelines. WHO came and get out and come back and so on. So it was a really hectic handling of this issue in therapeutic management, pharmacological therapeutic management. This is one question. The other questions for you, Dr. Al-Arabi, Professor Arabi, there are hundreds of clinical trials on is going already, and it was done already on the medication, the curative side. Is there any trials, into your knowledge, about the preventive medication? Especially, there is no clear evidence that there is a vaccine coming out. There is a question about, is there any preventive medication, not curative, preventive? The third question is for you, Dr. Al-Maliky. What about the issues raised about ibuprofen, non-steroidal anti-inflammatory, AC inhibitors, ARBs, in the management of COVID-19? So these three questions. The first one is a common one. Why we have this hectic management of COVID-19, even we have a lot of strong publication from public health perspective.
Thank you very much, dearest brother Tawfik. حقيقة, these are extremely good question, and yes, there is question mark about why we didn't have a guideline at international level or national level, you know. And the answer is very simple, by the way. From the start, actually, we said, and by the way, there are a lot of public health research, but not necessarily focus on treatment. I mean, I published 1 or 2 papers on treatment with colleagues in my unit, including the hydroxychloroquine. What was one of the first systematic review we published. But if you look at the reason for that are twofold. Number one, there was very clear direction from people in public health and even colleagues in clinical setting from around the world, saying the only evidence we have are in public health measures, number one. And we know what are these public health measures, is basically about suppressing and minimizing the transmission. And this list of public health measures are well known, adapted hopefully by all countries around the world. The second things for treatment, as you know, 80% of the cases are mild. The best treatment for this is stay at home, isolate yourself for a whole week, and get the simple supportive treatment which appeared in the table, beautiful table Dr. Muhamed described. For those who need, because of the respiratory problem, or by the way, the oxygen level tend to go down, and many patients go to a very, very low level, yet they don't have that distress, which is called oxygen happy or something like that. There is a terminology for it. Again, what we have in hospital, as David mentioned beautifully, the supportive treatment. And we were learning who should really have oxygen only or who should need to be intubated. But yet a lot of people took the risk on trying various medication without actually following a proper procedure for clinical trials. And that is a risk. I know there are a lot of legal cases now, and in the future there will be legal cases for some of the patients we lost because some of the doctors in certain parts of the world venture with treatment which are not fully tested. If we followed from the start the reality of supportive treatment, we wouldn't lose so many patients. If we followed the public health measures, many patients wouldn't need to be in hospital. I go to Dr. Muhamed for his question, and then Dr. Yassen.
Yes.
Okay. Dr. Muhamed?
No.
I think you remember the question from
Yes.
Yeah.
So the NSAID use, there is no recommendation against the use of NSAIDs. There's, I think, one anecdotal report came from a French physician that he treated a child and ended up dying, and there was some rumor about the deleterious effect of NSAIDs. But in our protocol, we use it as indicated. So that is clear regarding the NSAIDs. As far as the ACE inhibitors is my area. So we use it a lot for cardiac patients. And we use it especially for a cardiomyopathic patient with reduced ejection fraction as afterload reducers. And they're very effective and very useful as a mainstay therapy for heart failure, the systolic kind. So the recommendation that we use or we have is if the patient is on it chronically and get the virus in whatever form, we continue it. We recommend against the discontinuation of ACE inhibitors for people who have taken it for a long time. However, if ACE inhibitors is indicated as a new therapy for a cardiac patient or non-cardiac patient, we do not recommend initiating ACE inhibitor if the patient has coexisting COVID in whatever form. I mean, the COVID and ACE came from the fact that the point of entry of the virus is through angiotensin converting enzyme receptor 2 in mucosal cells. And there's like, well, since this is the mechanism of entry of the virus, then there's possible interaction that those people can get worse or their situation can deteriorate if they are on ACE inhibitor, but there's no evidence of it. And this is the general recommendation. And again, this is not proven through trials. This is sort of what the Association of Societies have come up with.
I think we have Dr. Yassen. We have 12 minutes and we have many questions. So I want a brief answer, please.
Sure.
I'm really impressed with the number of questions. Carry on.
Well, regarding the question about why guidelines are fluctuating and changing, I think on one hand, during this pandemic, the number of clinical trials have been very impressive. The number of cases increased exponentially, but the number of trials increased also big time. But we had many trials, but unfortunately there were few. Only few trials had high quality and they lead to conclusive results. And part of being prepared for pandemic, and pandemic's gonna be with us. I mean, in the last 2 centuries, we had so many pandemics. This is the largest by all means. We should be prepared in terms of research. And today we have several examples of people using medications that are off-label easily. You could prescribe antagonists for IL-6, IL-1, convalescent plasma, no restriction. But if you want to do a clinical trial, believe it or not, there are so many difficulties. Our health systems makes it very easy to prescribe medications right and left, and make it harder to conduct clinical trials. And I think we need really to think about it the opposite way. So we need to make clinical trials much easier and make it harder to prescribe these medications.
Thank you very much indeed. As you know, the fever again about the Russian medication, the news of the new discovery in Russia and announced even in some countries by ministers and politicians. So Avigan, any view from both of you, David, on Avigan? Muhammad, Dr. Muhammad?
I have a general rule, and you know me, Dr. Salman, you know me. These are Facebook therapies. I don't
fully agreed.
This question came from an academic in Iraq, Ali Abu Timman, and he's a well-known physician in Karbala. And it's really received so much attention in his country. And I'm so relieved to have such a crispy answer about it. We have also from Stella a question on dexamethasone. They said it's widely used in respiratory condition. So why we don't introduce it as a first line of treatment? And I think, Muhammad, you answered that, but any additional comment?
Sorry, what's the agent?
This is the dexamethasone. I mean, the British drug. From the recovery, they call it the British drug, which is not, of course, it's not new at all. And we don't have any new medication, but it is used widely. So why, she said, asking, why wasn't introduced as the first line of management?
Right. Well, I mean, we know, well, when the first epidemic started appearing, we started talking about immunity, that the immune-compromised patients are the most susceptible. So if you are on steroid therapy, you're probably, and you get the virus, you're probably not end well. So, I mean, as a common sense, to use a steroid in a viral infection that particularly attack and weaken and kill immunocompromised patient, then it wouldn't really be, it would be a huge risk to take. However, as our knowledge evolved, and especially the data that came out of Italy, I think the Italians first used dexamethasone, came out of Europe. Then we started understanding that at an advanced stage of the disease, it's really the systemic, the inflammatory response even in isolation of the viral effect is what end up killing the patient the most. And it's like, well, since it's an inflammatory process, then why don't we use anti-inflammatory? So it started being used with with huge precaution, until it gradually became a standard therapy, and then now we have the recovery trial proving it. So I think it has to do with how we evolve in our understanding of the virus and the role of inflammation in it.
I have this question repeated from many colleagues about if you got fever or if you got mild symptoms. Now King's College, from the database, they give us even different type of symptoms, including loss of smell, appetite, diarrhea, and many other symptoms, which is not necessarily the classic one. The question from many sources, as I said, you tell us to stay at home, but you don't give us any instruction what to do at home. And I think this is actually very sensible. It was very clear, the message in the UK from the Prime Minister, not from me, not from anyone from public health. It came from the Prime Minister on daily basis on TV, on actually interviews with the Minister of Health, with the Chief Medical Officer, literally on daily basis. So what's your view, Dr. Muhamed and Dr. Yassen? Lulwa and
Sure.
Yeah.
Well, now, especially in Iraq setting, where we have sadly an implosion of the health system that is just not able to accommodate the rising number, this is what I advise, based on our experience here in the US, based on common sense, based on science, is that if you are young, let's say below the age of 60, with no comorbidities, and you have only symptoms of fever, the cardinal symptoms, fever, cough, myalgia, loss of taste, loss of appetite, fatigue, this is still considered mild, and you can safely treat yourself at home with basically nothing. Nothing. You just protect others, you isolate yourself in a room, protect others from, you can use vitamins and zinc as you wish. We don't have evidence that they help, but if this is what you like to do, then do it.
And paracetamol if you got headache or
paracetamol, all the symptomatic treatment for fever, anything. You know, eat well, drink well, keep yourself hydrated, aerated, all of that. Then in whatever patient category, if you have started having shortness of breath, even with exertion, then the red flags start being raised that you might be progressing from the mild form or to a moderate or more severe form. And then depending on where you are, I mean, if you are in the Iraq setting, for example, then probably you still can be monitored at home. The oxygen can be delivered and whatever, be monitored. But in a normal country, let's say Saudi Arabia, UAE, London, and whatever, if you started having dyspnea, then seek attention, and then you can be admitted, you can be monitored in some sort of setting or facility. But as long as the line of demarcation between the mild form of the disease is dyspnea, shortness of breath, is what differentiate between cases that can be managed at home and things that can be more serious. And those dyspnea, whether it's mild, whatever, can stabilize at home and lead to recovery. It can progress, and sometimes progress very quickly, sadly. And then this depends on where you are and what kind of health facilities you have.
Lulwa, I think there is a question for you in primary care setting, and I'll ask colleagues if you want to add anything like that. Patient apparently with any suspicion of the disease anywhere in the Arab world, they just go, they walk to the hospital, or they drive to the hospital, drive to the primary care center, and indeed drive to the private clinic. And the data showing that in their way, without taking any precaution, they infect about 10 people unknowingly. So what are the procedures, Lulwa, in Qatar to prevent that from happening?
Yeah, I will talk from my side, from health center side. In primary care, we have different methods. So when the patient enters, he should take a precaution by wearing mask, wearing the gloves, and then we have application in our system. It's called ihtiraz. So he will show that he is either diseased or he is well, or he did the test before. So, and this is it's applicable in all sector and all even the malls. They check your phone that you are diseased or not. So if you are well, it will become green, or if you do the test, it will become gray, and red if you are diseased or have corona before. So after that, when he entered the health center, at the entrance, we have a greater nurse and a greater doctor. So they ask the symptom of corona, they have a symptom of upper respiratory, any contact, and then we will decide the pathway, either if it's mild to see the GP, or if we suspect a coronavirus patient, we will guide him to isolation room. Also, the isolation room under certain temperature, with the certain doctor sitting with certain assigned nurses in this room, taking with taking the precaution to wear a PPE, take the test for the patient, and then also we have a system. It's with other health sector in Qatar between the primary care and secondary care. We will enter all the information about the patient.
Thank you very much indeed, Dr. Lulwa. That explains it all. Our time is over. In the last dying second, I just want to thank you all. This is indeed one of the most interesting webinar I ever have had for some time now, although I have almost a daily webinar, but I learned so much and it was so super. I apologize from all my colleagues who send us a lot of messages, thanking you, our speaker, Professor Muhamed, Professor Yassen Al-Arabi, Professor Muhamed from United States, Dr. Lulwa Al-Muselmani from Qatar, and David Rawaf from London while he's on duty. Thank you very much. And last but certainly not least, my dearest brother, Professor Khoja. Thank you very much indeed. And next week we have interesting session from Hanan, Assistant Director General for WHO, on the burden of AMR and COVID-19. Thank you very much indeed. Have a lovely evening wherever you are, and see you next Wednesday. Bye-bye.
Thank you very much.
Thank you.
Take care. Bye-bye.
Thank you.